So my presentation will be about cancer pain basics, about the treatment, pharmacological, non-pharmacological treatment, breakthrough pain, and about the multimodal approach to the cancer pain. The cancer pain is very common, and its intensity progress intensity increases with the progress of the cancer. In 60 to 90% of the patients with metastasis, the 60 to 90% of the patients, they experience significant pain. And the pain is of the complex and mixed etiology. So we have nociceptive, neuropathic, specific tumors, post-operative, post-radiotherapy, and post-chemotherapy pain at once. The effective treatment is an imperative. It can influence the quantity and quality, and also the quantity of the patient's life.
Is it not working?
No.
Sorry. Let's just try. Can you try again? Okay.
So we start with the medical examination. We make the patient's check with the history, because the set of the diagnosis is very important, because the treatment of the different origins of the pain is different. So we start with the discussion. We use different questionnaires and the scales. Then we ask the patient about the severity, quality, location, and duration of the pain. What is the pain? About the associated disorders like anxiety, depression, sleeping disorders, and so on. Then we make also the physical examination. We check the general state and the local state of the patient. And if it's needed, we use also the additional tests like laboratory tests, X-rays, CT, MRI, and so on. And we also cooperate with our psychiatrist and psychologist, so they perform the psychological tests of the patient. The cancer pain treatment should be administered in regular intervals. Non-opioids and opioids are used. The golden standard by the cancer pain is different as by the non-cancer pain. The opioids are the golden standard. And we use the short and long-acting drugs, the adjuvants for the neuropathic pain. Then we have also treat the side effects, and we should not forget also for the non-pharmacological treatment of the pain. Our colleagues will speak about the non-pharmacological treatment in the next session. The current state is like this, that the long-term survival of the patients with the cancer is increased. So we have to perform the long-term treatment of the patients with as possible as few side effects as possible, and as high as possible, so that we can reach the high as possible quality of life of the patients. Here you can see the three-level approach of the cancer pain. It is made according to the WHO recommendations. By the mild pain, we use non-steroids, paracetamol, and metamizole. We often skip the second step and go to the more potent opioids like morphine, fentanyl, methadone, oxycodone, hydromorphone, buprenorphine, and tapentadol. Here you can see the three-ladder approach. Once again, we often skip the second step and add the fourth step. That are the interventional techniques of the pain. As I said before, by the severe pain and in palliative medicine, we often skip the second step because the mild opioids are not so suitable to manage the severe pain, and they have a lot of unpleasant side effects like nausea, vomiting, dizziness, and they are not so potent, so they are not so efficient than the more potent opioids. First of all, we should remove the cause of the pain, but that is not always possible. We use the surgical treatment, radiotherapy, and chemotherapy. And if the pain persists, then we use this pharmacological and non-pharmacological treatment. How we decide which treatment will be used? It is used according to the type of the pain, somatic, visceral, neuropathic, or mixed, and of the severity of pain, if it's weak, moderate, or severe. The golden standard, as I said, are the opioids, but also non-opioids are used in combination with opioids. But we have to know that by the increasing dosage, the effect does not increase, and the side effects can be also life-threatening. So they are not so suitable. They are also used just as the adjunction to the opioids. So we can use decreased dosage of the opioids, and we have less side effects of this group of the medications. Here are some of the groups of the non-opioids, non-steroids, then COX-2 inhibitors, paracetamol, and metamizole. Weak opioids, we skip this step very often, so we go to the strong opioids. We have various methods of applications, and here we don't have the upper limit of the dosage of the opioids. We increase the dose till the analgesic effect is reached. So it's different as by the non-steroids, where we have to go only to the upper recommended dosage. Yes. It is advised also to mix the opioids with non-opioids, but it is not recommended to mix different opioids. Here are some opioids. Morphine is the golden standard, but quickly the tolerance for the respiratory failure is reached very quickly. So it is not. You don't have a fear that the patient will go to the respiratory failure after some days of the treatment. Also, the sedation is present also, only in the first few days. Then methadone, it is a synthetical opioid. It works also on the, besides on the opioid receptors, also to the NMDA receptors, and is useful also by the severe neuropathic pain. And here are the different synthetical opioids like oxycodone, fentanyl, hydromorphone, tapentadol, transdermal buprenorphine, and so on. By the strong opioids, at the beginning of the treatment, severe side effects can be present, so the titration is very important. For the nausea and vomiting, we use pharmacological and non-pharmacological treatment. Pharmacological treatment is with metoclopramide, haloperidol, and so on. For the dizziness and disorientation, there is no treatment, but it is not so often by the younger patient. It is more often by the older patients. For most of the side effects, the tolerance is yes, in a few days, except to the gastrointestinal organs. So we have often the problems with the constipation, flatulence, abdominal cramps, and so on. We use again the non-pharmacological treatment like regular defecation, fluids, natural laxatives, and pharmacological treatments like lactolosis, metoclopramide, and other drugs. We use often also the other ways of applications like intravenous, but the patients have to be in the hospital when we administer the drugs intravenously. So we use often subcutaneous application and the other peripheral nerve blocks, central nerve blocks like epidural, suprachnoidal, and paravertebral blocks. In Slovenia, the subcutaneous application is very often used. We use the self-contracting pump, elastomers. There are a lot of advantages by the subcutaneous applications. Reliable application, effective resorption, lower doses are needed, so the side effects are not so common as by the per-os or the intravenous application, and we can use also the adjuvants. These advantages are the price, technical complications, slower effect, and complicated logistic. Because the patient have to go to the pharmacy every week to get another elastomer with the drugs. The limitations are anasarca, coagulation disorders, and so on. When we use those subcutaneous applications, when the per-os applications cannot be used, by the nausea and vomiting, by the swallowing disorders, when the higher doses per-os are necessary, and by the neuropathic pain, because the opioids, as Dr. Požlep said, the opioids are not a good choice for the neuropathic pain. And we have for the neuropathic pain only drugs which do not work immediately, like antidepressants or antiepileptics, and by this way of application, we can use another drugs like local anesthetics or ketamine, and we can reach the right effect in a few days. In addition to pain, we can treat subcutaneously also other unpleasant symptoms. We can add to the mixture, elastomeric mixture, another drugs for nausea and vomiting, as here are some of the drugs: metoclopramide, haloperidol, dexamethasone, serotonin antagonists, octreotide, then butylscopolamine, and so on. And by the terminal delirium, midazolam, clonidine, and in last years also the dexmedetomidine. We also perform the central nerve blocks, single shot epidural blocks, paravertebral blocks, then subarachnoid block, or the catheters. We can also insert the catheters into the epidural place, paravertebral place, or intrathecal. By the intrathecal technique, we can put the catheter up to the TH8, so the pain in the lower parts of the body can be covered with that kind of the treatment. The advantages are less systemic side effects because we use smaller doses. So the obstipation is present in 7%, versus 43% by the per os application. But we have also some disadvantages like invasiveness, complicated logistic, and infections. These are the main three disadvantages. We have to know that a great number of the patients do not respond well or at all on the dosage recommended by the WHO. Here on this slide you can see the table which shows the share of poorly responsive and non-responsive patients after 4 weeks of treatments. We can see that the percentage is quite high, and the severe side effects are also very common. The most common side effects are severe nausea, severe constipation, confusion, drowsiness, and we have to know that the group of the patients who survive the cancer is every day higher, and so the quality of life of the patients after the disease is very important. So we should use the medications and the route of the application in such a form that the quality of life and the side effects will be as low as possible. So and always we should use the multimodal approach, so we combine different classes of pharmacological substances and also non-pharmacological like blocks, subcutaneous applications, and also less invasive techniques like acupuncture and other techniques. But first, when the patient comes to our ambulance, we should titrate the opioids, and we still use the morphine drops to do this. So the patient takes the morphines for some days, 3 or 4 days, and there is not the higher dosage. So we say to the patient that he or she should take the drops whenever the pain is severe, greater than, according to the visual analogic scale, more than 4. So after some days, we can convert the dosage into the long-term acting opioids per os or transdermal form. We often see that the doctors, general practitioners, immediately use the transdermal form, but that is not the good way, because the effect it's not immediately after the application, and we cannot officially titrate the drug. So the first days the patient should always take only the morphine drops, and then we convert the drop into another forms and another substances. We should not forget also on the breakthrough pain. You can see on this slide that the persistent pain, the basic pain, can be treated efficiently, but we have the peaks of the severe pain, which lower the quality of life of the patients, very lower, and we should always ask for the breakthrough pain. Breakthrough pain is very common, but it's not given enough attention, so the patients does not know that that is important. So we have always asked the patient about this pain. So it is imperative to set the appropriate diagnosis and treatment. And breakthrough pain should be managed when, according to the visual analog scale, the pain is greater than 2. But as we see on this slide, the breakthrough pain, it's mostly very severe. Okay, yes. Non-steroids should never be used for the breakthrough pain, always only opioids and short-acting opioids. How frequent is the breakthrough pain? 50 to 60% of the patients experience, with cancer, experience also the breakthrough pain. Okay. It can be divided into two groups, but the first group, acute, short-term duration, moderate to severe, with average duration to 30 minutes, it's more common than the pain with the longer duration. So the very useful are the substances which act very quickly, like sublingual fentanyl and other, also the intranasal fentanyl and so another drugs. Also the fentanyl for the breakthrough pain should be titrated by the patients, and the highest recommended dosage is 800 micrograms. If I make a summary, the treatment of the cancer pain should be always multimodal, with the different groups of the medications, different methods of the interventional and also uninterventional ways of the treatment. So we also always combine different drugs and different methods for this kind of pain. But the golden standard are opioids, that is different than by the non-cancer pain.